It is top of the hour. Good afternoon. This is Laura Young with the Department of Psychiatry at UT Tyler Health Science Center and the CPAN and PeriPAN program. Today we are so thankful to have Dr. Kimberly Gashanis here with us. She is presenting a session that she presented last year, which was quite well received, and we've asked her to rinse and repeat that session for us again. It is an incredible session supporting pediatric patients exposed to trauma and loss. And I'm going to just read her bio here real quick and stop sharing for just a moment. That way she can go ahead and get her slides up. So Dr. Gashanis is from our sister hub down in Galveston. So she is a licensed psychologist and assistant professor at the University of Texas Medical Branch in Galveston, and she is in the Department of Psychiatry and Behavioral Sciences there. She received her PhD from the University of Texas at Austin, where she studied integrated pediatric healthcare and school psychology. Her doctoral training and fellowship at Dell Medical Center in Austin and at Texas Children's Hospital in Houston allowed her to further her expertise in trauma-informed pediatric psychology and consultation. Dr. Gashanis' work at UTMB currently revolves around trauma-informed clinical and research initiatives through the Texas Child Mental Health Care Consortium, which helps youth, families, and communities affected by significant stressful events, disaster, and suicide. She's passionate about improving equity and access to culturally sensitive and preventative mental health care, and sees her roles as an educator, clinician, and researcher as essential components to that mission. In addition to her work at UTMB, Dr. Gashanis also serves as a board member at the Early Career Division and the Early Career Division Chair for the Texas Psychological Association. So I am going to go ahead and turn this over to you, Dr. Gashanis. I know that we'll have additional folks joining us as it is now just the top of the hour. And I'll go turn my camera off and my mic and turn it over to you.
Great, thank you. Thanks so much for having me back. I'm happy to be here anytime to talk about this topic. It's very close to my heart. So I can see the chat. I'm happy to kind of take note of any questions. I think there might be a scheduled time at the end for more question and answer period. So I will kind of cruise through, but I'm happy to kind of pause if there are any big questions along the way as well. I don't know if that's allowed. Sorry, Laura.
Absolutely. Let's make
okay.
it interactive, Dr. Gashanis. It's a great opportunity to really be collaborative here.
Okay, good. I've done a couple of these in the past where it was supposed to be reserved for the end. So let me retreat back to the beginning of this and say, if you have questions, please feel free to put them in the chat or raise your hand. I'm happy to pause along the way to answer anything. So today's session is about supporting pediatric patients who have been exposed to trauma and loss, specifically bereavement related to the death of a loved one, or as you might often see with children, the death of a pet can also be a significant experience for some of these kids. So our objectives today, you should be able to recognize common and problematic reactions to trauma. You should be able to identify what traumatic stress looks like, including traumatic grief, and patients, their families, yourself, your colleagues. Hopefully you'll be able to identify 3 phases of trauma-informed pediatric care that has been associated with a couple of different models specific to preventative health care and behavioral pediatrics. And then finally, you should be able to create a plan for how you can immediately implement at least a few of these strategies. I plan to make it really simple for you, and also understand how you can support kids and families who have been exposed to traumatic events in your clinic starting now, essentially. Can I ask for just a show of hands or a reaction Thumbs up for anyone who's been trained specifically in trauma-informed care already, for those of you who are pediatric providers. Okay, we've got a couple. Cool. Awesome. Okay, so not as many as I was expecting, so it's good. I hope that you learn a lot today. So the outline for this session will go as follows. I plan to introduce to you just some of the prevalence and important information to know about trauma in children, and why we're talking about this today specifically with you. I would like to review the 4 R's of trauma-informed care that have been defined by SAMHSA. Provide an overview of the 3 phases, like I said before, of a well-studied trauma-informed preventative pediatric behavioral health model. I'd like to discuss some strategies and give some examples of how we would intervene at each of those 3 phases, and then review some specific resources for you, as well as recommendations for how you can either implement or learn more about how to implement these types of trauma-informed practices within your own clinical practice. So the National Child Traumatic Stress Network, if you're not familiar with this, is a national kind of research consortium, for lack of a better way of saying it. I don't know if they would call it that, but it is a group of national centers, individual researchers, places that dedicate their interests clinically and research to traumatic stress in children. And they are really kind of the host and hub of a lot of the information that we source when we're working with kids in this population. So their definition of trauma-informed healthcare is medical care in which all parties involved are able to assess, recognize, and respond to the effects of traumatic stress in children, caregivers, and healthcare providers. So as you can see, this is kind of an all-inclusive idea. All parties involved, we'll talk about this a little bit in a second. It really means all parties involved. So we're not just talking about the doctor that's seeing the patient, we're also talking about the the front desk staff who are welcoming patients. We're talking about the security guard that stands outside the door. We're talking about the nurses. So everyone involved, every material involved in caring for these patients matters. And that's a part of the scope of trauma-informed care. The other thing to note about this moving forward is that trauma-informed care subscribes to what we call the circumstances view, which is that trauma can result in changes in behavior that are functional in the short term, but that can have really negative side effects in the long term. So sometimes we see children who have been affected by these circumstances, and we want to question what it is that happened to this child that makes them experience the concerns that they're presenting with versus what's wrong with the child themselves or what's wrong with the family and their ability to resource. So first, let's start with SAMHSA's trauma-informed approach. So they've defined 4 R's of trauma-informed care that should apply in any trauma-informed clinical setting. And these are really designed to help differentiate from trauma-specific services, because this isn't a service necessarily. This is a model of thinking. It's an approach to working with like a stance, if you will, for working with these kind of high incidence and high risk occurrences. So the first R is to realize the widespread impact of trauma and the risk factors that contribute to the development of difficulty following exposure to a traumatic event. We'll talk a little bit more about that today. So recognizing what this actually looks like. So realizing the prevalence of it, realizing what contributes to traumatic stress reactions and traumatic grief reactions in children, and then also being able to actually recognizing it when it shows up in front of you in your office, or in your team meetings, or in your colleagues in the hallways. The next R is to respond effectively. So not only do you understand the scope of trauma exposure in your patients. You can recognize what it looks like when it shows up, or if you can't personally, you're at least screening for it. And then you're responding in an evidence-based manner to fully integrate what we know about the impacts of trauma exposure with your own policies and practices. And then the last and probably most important R is to resist re-traumatization. It's a double R. So we want to actively shape our environment, including what patients see, what they hear, what is in the waiting room and in the exam rooms with them, the people that they interact with. We want to be intentional about reducing potential re-traumatization as much as possible. So, the role of a pediatrician in all of this is essential. JAMA reported, and my reference list is made available at the end if you're interested, but JAMA reports that about 60% of children in the United States will have faced at least one significant traumatic experience before the age of 18. And just to clarify, this is an A1 trauma. If you're not familiar with that language, it's a life-threatening experience that a child was either directly exposed to or secondarily exposed to, made aware of, where they felt their life was impacted or their safety was impacted or their loved ones. So it's a very specific definition of trauma. And we see a very high incidence of this occurring in children in the United States. However, according to the NCTSN, their studies show that up to 80% of pediatric patients who are presenting to your offices have experienced some level of traumatic distress after an event like this occurs. So the incidence in your pediatric office is much higher than the general population because you're the one that they're coming to for help. So we see this true for all types of psychological and medical trauma, but we also see it very frequently in pediatric patients who have been exposed to a life-threatening illness, a difficult prognosis or diagnosis, chronic illness, accidental and intentional injuries, or painful or intrusive medical procedures. And we know that out of those kids who have experienced those medical traumas, about 21%, anywhere between 15 and 20% of them actually do end up developing PTSD. It's also important to recognize that it's not just the child or your patient who can be impacted, as you are probably aware, and honestly, you've probably all experienced to an extent yourselves. Trauma can impact the entire community. So we want to be looking kind of ecologically across all the scope of support for a single patient or a single child, their family, their siblings, their school community, their church. The way that trauma shows up can be very different for every individual. So resilience is the most typical response for children. Everybody's heard this phrase, children are so resilient. And that's true. We have a lot of data to support that. However, it is with a caveat that the children who are resilient are those who are well supported and nurtured. So we have to make sure that this child has at least one strong, nurturing social support system in place to be able to say that they are more than likely going to come out of this experience with resilience. Even when experiencing acute or peritraumatic symptoms, which I'll define for you in just a second, many pediatric patients and their families exposed to these types of events are able to cope pretty well with just basic protective factors like having a supportive family or people that understand what it's like or can communicate, that they're there for them, having time to cope with what's happened. Children with a caring adult in their life. It really is simple. And oftentimes you as the pediatrician are the person that can fill that role of checking in and asking questions and offering that support. Some kids, though, do develop more persistent symptoms of traumatic stress following the normal period of time that we would expect to see these. Sometimes that does include a full diagnosis of PTSD, which we know impairs them physically, psychosocially, in many different capacities. We've learned from some pretty seminal studies that exposure to trauma can literally change your body and your brain functioning. It can change your immune system. We know it can impact your health in many different ways that sometimes don't show up until much later. So the trajectories of when a child presents with post-traumatic stress, kind of secondary symptoms or sequela of that event, it can vary from months to years later. So being preventative and using this kind of 4Rs approach and the preventative model that I'll share with you a little bit later today can be really important for preventing some of these concerns from developing into more significant impairments. We know that as the pediatric provider, whether you're a nurse, a behavioral health clinician who's embedded or integrated into pediatrics, you're the pediatrician yourself, you are on the front lines. Our medical techs, you guys are the ones that they're coming to first, usually when something like this happens. So you have the greatest potential, really outside of the school setting, for both early identification and responding to potential traumatic stress. Unfortunately, a lot of pediatricians report a lack of knowledge, a lack of time, a lack of resources as the biggest barriers to addressing trauma-informed care in their practices. So the purpose of today is to simplify it for you, give you a quick overview, kind of the primary tenets of how you can begin implementing these types of models in your practice, how to screen and diagnose for these issues, and then how to make appropriate referrals so that it can be a really fluid system that's easy to integrate. So just for some realization for the first R on the SAMHSA model, just to kind of give you an overview of where trauma comes from in kids. So obviously it can come from anywhere. Environmental, it can be macro, like climate change, if you're familiar with that research. Immigration, these are two commonly researched areas that we are looking at in the traumatic stress field. Natural disasters, unintentional injuries, things that are happening in the environment or events that occur outside of the child. We also see a significant amount of traumatic events occur that are caregiver related. So whether that's direct violence between the caregiver and the child, whether it's parental substance use or mental health events, death of a parent, some kind of maltreatment, or even just separation from a parent, like if a parent's incarcerated or deported. So these are events that can produce traumatic reactions in children and families. And then, of course, medical trauma, which you are all familiar with, so I don't need to review that for you. What predicts a child's movement from the trajectory of typical resilience to post-traumatic stress? And we know it's a balance of risk and protective factors. So how much risk are they coming in with? And then how much protection do they have in place to buffer the effects of these experiences when they occur? Our social context really informs how we humans with our various identities, how we each experience the world around us, how we understand and navigate the world around us, their systems, the structures, the institutions that support children in this country. And so we really do have to think about the context, the society, the communities, the schools, the families, all the way down to the individual and their own beliefs and understanding about what happened to them. It's very important. And trauma and its sequela, like any other internal experience, occur within the individual, but that individual exists within these contexts. So it's really important as a pediatrician to broaden your scope and recognize it's beyond necessarily the symptoms that they're showing up with that day that need treatment. There are other ways that you can be supportive and that you can be the person facilitating this resilience for these children. The strongest predictor of recovery from childhood trauma is a safe, stable, and nurturing environment. So how do we foster this as pediatricians? It's a very easy formula. Like I said a second ago, it's a balance of risk, vulnerability factors, and balancing those with strengthening our protective mechanisms and making sure that we're promoting the things that we know work for kids in these circumstances. So evidence-based practices that we know are important to reduce the impact of trauma on the individual outcomes. So just some examples here. A protective factor is something that buffers the adverse effects of trauma. A promotive factor is something that enhances positive adjustment, regardless of their risk factors. So if you know a kid's like really into sports, but after this trauma, they stop playing soccer, we want to promote the things that we know enhance their positive adjustment, keep them plugged in, make sure that they're still getting what they need. And this informs that kind of mindset approach rather than just kind of a checklist of, symptoms to treat. So some of the more important risk factors that can contribute to an increased response to traumatic events includes how threatening this event was perceived to be by the child. So that's a very subjective risk factor. How scared were they? How much did they fear for their life or their loved one's life? Violence exposure significantly increases risk for secondary traumatic stress. So, secondary symptoms and effects of traumatic stress. So exposure to a violent event, whether they were directly involved or they witnessed it. Bereavement, so the death of a loved one is a significant risk factor. Chronicity, so how often is this occurring? Is the trauma repeated? And then the age. Typically, we see younger kids suffer, are more resilient, but do suffer stronger reactions to these risk factors. Whereas the older kids typically have more resources to cope, but then they become more subjected to risk factors related to secondary effects like depression, anxiety, suicidality. Some vulnerability risk factors to keep in mind. That's this top arrow. I don't know if you can see my cursor here. I have a laser pointer here. Vulnerability factors that we have to consider are things that are present before the trauma occurs, or they could be like secondary adversities that are weighing down on the child. So these are things like age changes in their daily routines or living circumstances. So if a caregiver dies, if they have to move to a new school district, if they have to start waking up at a different time to drive further because dad works full time and mom didn't, there's lots of different factors that can contribute here that make the child more vulnerable before the trauma occurs and then can impact them after. Some known protective factors are, like I said a second ago, the safe, nurturing environment. Social support would be the second most important protective factor that we've identified. So getting kids plugged in, making sure they're maintaining routines, continuing to go to school. No, don't take them out and homeschool them unless it's medically necessary. Keep them plugged in, keep them connected to social support systems, and seek more social support as needed. And then make sure that if it's an early childhood, like a very young child, make sure that that caregiver and child relationship is healthy. So make sure that that caregiver feels confident that they know how to support their child. When we see trouble and outcomes here is when these things are out of balance, when there are less protective than there are vulnerability or risk factors, and we are not promoting the things that are already working well for the patient. Okay, so the next R is recognizing signs and symptoms of trauma in our clients and our families. and our staff and ourselves and our first responders. So anybody within this system that's providing care to our patients, this applies to. So I'm going to go through the traumatic stress reactions broadly, and just kind of give you a sense of what these might look like when they show up in your office. So we can objectively know the criteria that are listed here from the diagnostic manual. But unless we're actively screening, sometimes detecting and differentiating these symptoms can be really difficult because they can look like a lot of different things. So the important things to keep in mind are, was this child exposed to a significant traumatic event or death? And are these things co-occurring? And sometimes screening is the only way to see that. However, there are a couple of key presentations that can be really helpful to be aware of when you're working with kids. So let's dig into what some of these might look like. So exposure to, I'm missing a slide here, guys. I'm sorry. Exposure to a life-threatening event is the first criteria. So in order to be considered reacting to a traumatic event, you have to have experienced a traumatic event. And again, this is defined as life-threatening. So it is subjective in the sense of how they respond and the severity that they attribute to it, but there has to be a life-threatening event that has occurred to be considered a trauma by definition. The second symptom here is re-experiencing. So re-experiencing is when we have, like it says, intrusive experiences that come in to our consciousness that are related to what happened. So this can include lots of different things, but this is where we see things like nightmares, flashbacks, intrusive images or memories that pop up when they don't want them to, repeated thinking or just thinking too much about something. Often people, you hear them complain about things like, every time I close my eyes, I see this, or it feels like it's happening all over again. We see distress at certain reminders that pop in. If they hear a loud sound, they have a memory of what happened. If they hear sirens, they have a memory. It causes distress. And then, of course, nightmares, which are common in children, but we hear them increasing in frequency and distress as a result. This third symptom of PTSD or traumatic stress reactions in youth is avoidance. And this is a really important one. So this is where a kid will strongly avoid people, places, situations, words, even objects, smells, sound. They will actively do whatever they can to keep away from the things that remind them of what happened. And sometimes this is conscious, sometimes they don't even realize that they're being so avoidant. What happens is the world becomes very small. They restrict themselves to the point where they're not able to access the kind of supports that they need, the social supports, the activity levels, the basic health behaviors become limited because they're avoiding so much. So when you hear kids say things like, I try not to think about it, or parents say they won't talk about it, they just shut down. You hear kids say things like, I'm never going there again. Or, parents will say, well, he won't even drive that direction anymore. So just little things like that you can hear that it is an avoidant way of coping with something that's happened. Examples of the next traumatic stress criteria, which is negative changes in cognition or mood. So what we mean when we say negative changes is that there's like a cognitive shift to what we kind of call like a negative filter or the dark cloud. So it can include any kind of way of thinking that's kind of shifted to more negative or untrustworthy types of thinking styles. So this might be related to themselves. It could be related to others. It could be related to the world at large, being unsafe. These are the kinds of ways of thinking and patterns of thinking that make kids feel anxious, that create these intense fears about what's going to happen next or what could happen, and typically lead to more avoidant symptoms. So you'll hear these kind of exaggerated negative thoughts, like almost catastrophizing or overgeneralizing the risk of, I'll never be able to ride in a car again, or I'll never be able to do this again. Or you'll hear caregivers say they don't trust anyone, or they don't trust doctors anymore. They don't trust their coach anymore. You also hear a lot of blame and guilt that comes out of this negative shift. If I would have just done this, this wouldn't have happened, or it's my fault because I didn't do this. You might hear caregivers say something like, they were such a happy, bubbly kid before this, and now they're completely different. So those are signs that they've seen this shift, usually behaviorally first for kids, but more often than not, you can hear signs of this negative cognitive or mood shift. Another one that's really common for all teenagers, essentially, but definitely one to look out for kids after a trauma is these kinds of like detached, numb types of thinking of like, I don't know, I don't care, it doesn't matter, what's the point, those kind of negative shifts. And then finally, hyperarousal, which is a physiological term intended to be. So this can be kind of hypervigilance, being overly careful and attentive to their environment, but it can also be this physiological response. The startle response is increased. They're more irritable. They're having trouble sleeping, eating, relaxing, concentrating. This is where we often misdiagnose things like ADHD or learning disabilities in kids post-trauma. So that's always something we talk about with families who are coming in for an ADHD evaluation when this kid just got placed in kinship custody because their parents got incarcerated for like a domestic violence event. So we always want to be careful to say like, well, what's really going on here? Where did this begin? Some signs that this is showing up could be kids saying things like, I know it's safe, or like, I understand that it probably won't happen again, but I still don't want to do this, or I still can't get myself to do this, or I always feel like I'm watching my back, or I always feel like something's about to happen. We see a lot of times kids become very sensitive to certain sounds or loud sounds in general, or just surprises, someone touching them on the shoulder, things like that. Increased irritability is pretty much a symptom of everything in children and adolescents, but that's definitely a common one here. And then, of course, difficulty with kind of basic executive functioning, sleeping, concentrating, grades start to slip, relationships are failing, work is slipping, things like that. Let's see. Traumatic stress reactions can also include some dissociative features. So they can occasionally include things like spacing out, these unrealistic, surreal experiences, kind of outer body experiences, feeling like they're living in a dream, or a foggy sense of cognition, feeling like they're not really there. These are much more rare in young children than they are in older adolescent, young adult, and above, but they can occur on occasion. Okay, so beyond the symptoms and evolution of post-traumatic stress, we also see secondary adversities that arise from trauma. And to be frank, these are often reported more frequently than post-traumatic stress. So even if a child's resilient to developing PTSD, that doesn't mean that they're resilient or that their circumstances or environment is resilient to some of these secondary adversities. So some that we often see are significant impacts on caregiver mental health, especially in cases of bereavement. If you see the death of a co-parent, for example, where the parent, the grandma that lived in with the family, we can see significant declines in caregiver mental health. Even if the caregiver wasn't involved in the trauma, witnessing their child experience a traumatic event can significantly impact some parents. So we do have to pay attention to the health and wellness of the people providing care for these kids. Sometimes certain traumas lead to conflict in the family, increased stress. It can lead to family separation. We can see significant legal problems as a result of traumatic events, depending on what happened. This can look many different ways. It can be institutional, CPS, child welfare involvement, but it can also be things like, drunk driving accident created legal fees, and there was a lot of court appearances, just things like that can be really distressing on the family and the child. Obviously, bereavement from the death of a loved one, and then more broadly, grief from experiencing a loss. So, for example, I worked with some kids that were part of the Santa Fe school shooting, and it was their, last couple of weeks of school, and they were grieving the fact that their last few weeks of their senior year were impacted by this school shooting. And this is what they were leaving with. This was the memory that they were leaving school with that year. So there's different forms of grief. It's not always death related. It can be loss related. This would be a secondary adversity, though, not a traumatic event in itself. Discrimination and victimization can be both secondary adversities and risk factors. So it's definitely something to keep in mind, and especially in today's socio-political climate, there's a lot of this going on right now, and it is impacting kids who are witnessing it and experiencing it themselves. So making sure you're open and respectful and practicing good cultural humility, attending to interpretation needs, and making sure that materials that you provide patients are appropriate for them. And then finally, changes in daily routines or lifestyles. As I mentioned before, certain traumatic events can really impact the day-to-day life of a child or a family. And so those are secondary adversities that sometimes get lost in like screening for a traumatic event or focusing on symptoms. But these are things that can really impact the outcomes just as much, if not more in some cases. Okay, I'm going to pause right there. Just went through some of the criteria for trauma, some of the secondary adversities you might see show up for these families. Does anyone have any questions at this point before I go through some of the grief symptoms?
I don't have any questions in the chat, but people are definitely welcome to unmute themselves and ask questions at this time.
Yeah. Well, interrupt me if you need to, but I'll move on. I do think it's important to talk about grief reactions because they are a significant contributor to post-traumatic stress in kids. So when there's a death experienced in the family, it is inherently traumatic for a child when it's a close family member or caregiver. So a lot of people never really learn about this in their training. What is a typical or appropriate response to grief? In our culture in the United States, or at least in the South, it's not something that people talk about much. So I think it's important to just kind of be aware of this. I am definitely not going to read all of these words on the slide to you, but I want you to see this and be aware that there are developmentally appropriate responses that we would expect a child to have after the death of a significant person to them. So there are typical ways that they express emotion or express their grief, depending on the age or developmental level of the child. There are changes in how they perceive and understand death as they get older. These are things we know and expect to be true, but we don't often understand and are able to differentiate what is appropriate depending on these age ranges or developmental ranges. So you'll see here in each kind of developmental section a typical kind of response, what we usually see from kids in this age range or developmental range, their understanding of what death means, typically in this developmental level, and then the common reactions that we see after an event occurs. So you'll see changes from toddlerhood up to adolescence in how they express their grief, how it shows up for them. Typically, the younger kids are more outwardly expressive. They're kind of letting you know how they are feeling or thinking through play or through their behavior, whereas adolescents tend to be a little bit more reclusive. They tend to pull into themselves or seek peer support rather than family support in many cases. Adolescents we see often are grappling with, like, what does this mean about me? What is my life going to look like now that this person is gone? It becomes very identity intertwined for them. So those can be important factors to consider. And then we see a wide range of intense emotions in all age ranges. So that is something we expect after grief or after a death occurs. So reference this at another point if you're interested in it. I think it's important. And then I wanted to kind of share this slide to really emphasize the overlap between a grief reaction and trauma. Because, like I said, grief is inherently traumatic when it is a death of a close or significant loved one to the child, but there are also other circumstances that create grief, and there can be a significant overlap between typical grief reactions and how trauma or traumatic stress shows up. And to be truthful, we treat them very much the same. So I often treat kids using a trauma-focused therapy who didn't necessarily experience a trauma, but they are experiencing prolonged or significantly impairing grief. So we do treat them quite the same. So there's quite a bit of overlap here. We know that typically we start to get concerned when grief turns into a very prolonged or severe interference with their functioning. Another kind of alarming symptom that is expected, it's not necessarily normal, but we do expect it to happen in some kids, is reunification fantasies. So a lot of people start to freak out that this is a suicidal kind of episode for kids, but more often than not, it's just an expression of a wish to be with that person again. So not necessarily I want to die, but I wish I had died instead of them, or I wish I could be dead so that I could still be with them, or I daydream about dying so that I can be with grandma again, so curiosity and a wish to be reunified is frequently observed in these cases, but it doesn't necessarily mean that they're feeling suicidal. So it's very important to get a really good risk assessment completed for these patients. A lot of excessive and intrusive worry, that hypervigilance can be really, really extensive for these kids. They worry that something is going to happen to them like it happened to their loved one. What else in the world could happen now that I know that it's unsafe, that things aren't certain. And then big persistent changes in functioning. So difficulty maintaining ADLs, their academic or their work functionings slipping, they're becoming more socially withdrawn. They're really missing this person so much, they become lethargic, they're not able to feel good anymore. So very typical changes similar to traumatic stress, or sometimes it looks like depression as well. So I thought this was a really cool quote by an author that was featured in the New Yorker almost a decade and a half ago. But I think it's really apt. She said, scientists have found that grief, like fear, is a stress reaction attended by deep physiological changes. Levels of stress hormones like cortisol increase, sleep patterns are disruptive, the immune system is weakened. Mourners may experience loss of appetite, palpitations, hallucinations. So this really kind of mimics the definition that you heard earlier of traumatic stress and what these symptoms can look like. So I just think it's really important to consider grief as a trauma. Okay, so how do we respond? We realize that it's happening. We've recognized symptoms in our patients. Now, what do we do about it? And how do we fully integrate this knowledge with our next steps? So this is where this phased model of traumatic stress reactions comes in. This is published and maintained by a couple different organizations that work on it, but primarily CHOP, the Children's Hospital of Philadelphia, who have developed the kind of pediatric traumatic stress framework. And this is the 3 phases that they want providers to be paying attention to. So you can actually find training and additional resources on this on the website Healthcare Toolbox, which is involved in the resources later on here. But Healthcare Toolbox is an excellent website that can give you a ton of resources, including screening materials, additional CE trainings, and it's all developed by the Center of Pediatric Traumatic Stress. So there are 3 phases here that we're going to go through. For the sake of time, I'm going to move forward. And I want you to just be aware of this model that is a public health and preventative health model, a way of addressing kind of tiered systematically a trauma-informed model of care for pediatrics. So you hopefully are familiar with public health models already and kind of get the idea of like there are basic universal precautions that we're taking, like screening and making sure our environments are safe. And then there are targeted interventions and screening that we're doing for people who are already considered at risk or who have been identified to experience these risk factors. And then the clinical level, the tier 3 level, where we're referring up to a higher level of care when certain symptoms present or certain impairments present. So this 3-phase model is an example of that. I do have a case example here, but I'm honestly not sure if we're going to have time to get too deep into it. But I do want to present it to you just as an example. So this is a patient I worked with actually at Texas Children's Hospital several years ago, and he was a 7-year-old boy, had no health or mental health history. Actually, I lied. He did have a screening for ADHD when he was younger, but it was not confirmed. He was admitted via ambulance to the emergency department after a motor vehicle collision, which he experienced while playing a video game in his room, and a vehicle ran into his home and directly into his bedroom. And the car fortunately hit the bed first that he was sitting on, and it flipped the mattress over on top of him. So he was trapped under the mattress under the car. And he did experience a traumatic brain injury, a laceration to his shoulder. He got some bruised ribs, some mild blood loss. He was responsive. He wasn't suffocating or anything like that. So it was definitely traumatic, but he was also okay. So the problem here, to add in, just in case we don't get to time to get to this, is that his parents had just left him for the very first time to go down the block to the corner store to get groceries for dinner. So he had been saying, I'll be fine, like I'm okay, I'm just gonna play my video games. He was a very independent kid. And so they finally were like, okay, we're just gonna let it happen. Mom couldn't drive because of an injury, so dad had to drive her down there real quick. They were literally gone for like 10 minutes when this happened. So of course it's like the worst case scenario event that could have happened when they leave this child for the first time. Okay, so phase 1 is peri-trauma. This is the acute traumatic phase. These are the immediate moments and days after the event occurs. So this is where this potentially traumatic event it's objectively occurred. We know that it's happened, but the child may or may not perceive it to be stressful or life-threatening at this time. So we can't assume traumatic stress reactions, but we can assume that there might be some peri-trauma reactions or some acute stress reactions that are just inherent when you experience an event like this. It doesn't mean the child thinks that it's stressful, though. And then the bottom phase here is like the intervention piece. So what do we do about it? And this is where we just address emergent needs, safety, pain, medical care, and assess for risk and protective factors related to the development of PTSD. So is the parent struggling with a mental health condition? Does the kid plugged into social supports? How are they doing at school? Is there anything kind of socially that needs to be addressed to help prevent any of this potential stress from impacting the kid in a significant way? So I'm going to move past Jake for now. Phase 2 is the earlier acute phase. So this is post-event. So we're now in the days and weeks after the event has occurred. And this is defined as within the first 30 days. So the PTSD criteria require that it is after 30 days from an event. So this is the acute phase. This is where we expect acute traumatic stress. We expect interference still from things like pain. We expect fear and uncertainty. We expect loss and grief reactions. And so this is where screening can be really helpful. So screening for risk of acute stress reactions or screening for presence of acute stress reactions. So again, we know that that just because a child's experienced a traumatic event doesn't mean that they're more likely to develop PTSD. But we do want to keep an eye on these symptoms because as acute stress transitions beyond 30 days, it becomes post-traumatic stress. So we need to kind of keep an eye on them. So the intervention at this level is just helping people be aware of what to expect. Let them know, like, it's normal for you to have some nightmares for a couple weeks. It probably will go away within a few weeks, but we want to make sure that you're aware it could happen. It's normal to see these changes in functioning. It's normal to see a lot of stress and a lot of fear. Again, children are typically resilient, so it should reside within 30 days. However, for some kids, it doesn't. So our goal here is to just really educate, reduce their general stress level, reduce any surprise they might feel by any of these acute stress reactions showing up, intervene with known risk factors as we would have done in the peritraumatic phase as well, and then really focus on strengthening protective factors that we know can buffer against this transition from acute to post-traumatic stress. So getting them plugged in, making sure the parents know they should be going back to school. They do need to be reintegrated into their community. Make sure that caregivers are communicating, they're answering questions in an age-appropriate way. They're maintaining normal routines, and they're following up as needed. So in kids that are in this acute phase, we might want to schedule them more frequently for follow-up as maintenance to be sure that they're transitioning well out of this acute phase. Jake did not transition well out of this acute phase. He did not receive preventative intervention. He didn't get educated about some of the potential impacts this experience could have on him in the short term. And so within a couple of weeks, parents were really freaking out about the changes that they saw in him. So he was referred to my outpatient service at the time. And some of the things that they came in with was he's having trouble paying attention in class. He's not able to sleep really well. He's definitely having a lot of nightmares. And he's got significant separation anxiety, which is very characteristically different from the kid that he was before this occurred. So it's impacting his social functioning and his academic functioning because he just does not want to be away from his parents again. So this is where we transition into this is a mistake up here. It should not say early acute phase. It should say post-traumatic phase. So post-traumatic stress phase, which is phase 3. This is after 30 days and throughout the lifespan. So like I said at the very beginning, one of the things we know about trauma is that it can present at any time throughout the lifespan. So even if you experience something when you were 7 years old, it might not actually affect you until you're 27 or 47, depending on the experience and the secondary adversities that have come up. So this is where we start to see diagnoses of things like PTSD or other diagnoses that are clinically relevant. At this phase, we need to be continuing to screen them intermittently. So we should be screening for post-traumatic stress every time they come in to your office. If you have identified them, we know they're in this phase. We should also be monitoring those secondary adversities, like I mentioned before, and routine monitoring like you already do for most kids, the PHQ-9, anxiety measures, just making sure that we're kind of checking on that entire scope of functioning. Intervention at this phase is referral to a mental health professional that can provide evidence-based trauma-focused care. So if they're experiencing symptoms of PTSD, we actually have very good treatments for that, and we know how to do them. And there are plenty of people in Texas now being trained in this. So as a function of the consortium, this is an initiative that's been brought about. So we have lots of access to this right now. Trauma-focused CBT is one of the first recommendations, but there are other interventions for younger child and for older adolescents as well that can be helpful. So typically we're going to let our social workers handle this, our care managers, to address some of these secondary adversities, but we want to be really specific that we're getting people to an evidence-based and trauma-focused treatment if they are experiencing symptoms of PTSD. And sometimes you are going to be the only person asking those questions. So I did treat Jake for PTSD. We did about 3 months of therapy, weekly and biweekly. And I also did some parent training, some behavior management training to help parents with some of the separation anxiety and some of the ADHD-like symptoms that were present but exacerbated by this event. And then I also saw him again for a 6-month and a 1-year follow-up, which is kind of a standard procedure that I have, which is part of that preventing re-traumatization. I want to check in, make sure they're still maintaining some of the things they learned. And then finally, resisting re-traumatization, we've talked about this a little bit. There are some really excellent resources and training about how to modify your clinical setting and practice to kind of hit some key components here. But just for the sake of time and scope of this talk, I'm not going to get into this too much today. Just be aware that these things should be attended to. So just some resources for you all. There are several excellent and free trauma screenings that you can implement. These are very commonly used in medical settings because they're only 3 or 6 questions. Obviously not comprehensive because of that, but they're good options. The CATS and the CPS are very common. They both include a checklist of like yes or no. Have you ever experienced something like this? Natural disaster, witnessing someone getting beat up, like just typical descriptions, child appropriate descriptions of trauma. And then they usually also have a symptom screener on a Likert scale where they're rating the severity of the specific symptoms of post-traumatic stress. So this might be a good kind of universal or targeted screening tool, whereas these are going to be, we know that this kid's experienced a traumatic event and we know that they're showing some signs or symptoms. And so we're going to give them these to really identify, do they need a referral to the next level of care? And then for older teens and adults, we can use the PCL-5, which is a short kind of PTS checklist, very similar to these that are designed for children. I also included a whole host of resources, videos you can watch, different CE credits, really great articles and podcasts from the American Academy of Pediatrics, some excellent policy statements on why this is important and what you should be doing about it. Healthcare Toolbox, I highly recommend. It's a really great resource for these kinds of things. And then the NCTSN also has a pediatric toolkit that you can download. Dr. Keeshan up in, I think he's in Utah or Colorado right now. He has something called the care process model, which is a very well-researched, highly extensive trauma-informed care model for pediatricians that you can look to for good ideas. And then, of course, we have our references here. And I should mention, too, that the consortium also has a lot of access to trauma-informed care through both TChat, but also through the Trauma Research Network. So if you're not already familiar with the other initiatives of the consortium, you definitely should be. They can be an incredible resource to your patients. Okay, guys, we have 60 whole seconds to spare. So if you have any questions, feel free to quickly pipe in. I can hang on for a minute to answer them.
And you can also unmute yourself if you'd like. I'm going to pull up the the QR code for folks to get their continuing education and post it in the chat as well.
Let me stop sharing then.